While we wait for that to start, just want to say good morning to everybody. It's a real honor to be here and to kick off this first plenary session of the meeting. Um, you know, some of you may know I'm originally from Singapore, and so coming back to Southeast Asia is always a pleasure, especially because the food is, of course, unrivaled in the world. All right, so for the next 30 minutes, what I'm hoping to do is to share with you some of my thoughts on how I approach decision making in anesthesia and also how I think we can improve our analytical and our decision making abilities as anesthesiologists. And along the way, I'm going to make particular reference, obviously, to regional anesthesia because this is a regional anesthesia symposium, but also because it's my main passion and clinical interest. But if we take a step back, really, any anesthetic is a series of decisions. So even in the general anesthetic, for example, we're constantly making decisions about what drugs we're going to administer, what interventions we're going to perform. I will be honest though, those of us who are a little bit more senior, I personally I'm often functioning off routines and rote, and perhaps some of you are too. And that's usually fine because we all refine our standard recipes for common procedures that work well for us in most of our patients. But at the same time, we often encounter challenging situations or patients that require us to customize an anesthetic plan that will carry the patient safely and successfully through their perioperative journey. And so the decision on whether you choose to incorporate regional anesthesia and how to do that is part of this customization process. And what I want to do, that's using a real case from one of my daily practices. So, if you look at the list for the day, we see this removal of the hardware from the forearm as a day surgery procedure, which looks pretty simple, right? Usually, I will say, I'm not going to do regional anesthesia. Rather, a quick general anesthetic is probably all we need for this kind of procedure. But any decision is based on information. And so, the more complete our information, the better our decisions will be. So, let's get some more details or take a history, as I prefer to think about it. What I'm trying to do here is understand the patient's story so that you can anticipate what their needs are, their preferences, and also what the likely ending is to this particular chapter of their story. So, if we dig through the notes, and we're lucky to have an electronic medical record system that allows us to do that, we get this context. So, this is a 50-year-old patient who has continual pain after fixation of a radial fracture some 6 years ago. The hardware is thought to be contributing to their chronic pain, so they think we should take it out. But when we start to look at imaging now, we see that this isn't just a couple of screws at the wrist. This is actually a large plate going from distal radius to mid shaft. And that, as you can imagine, will require a large incision and a lot of muscular dissection going up into the proximal forearm. Now, when we look further at the pre anesthetic clinic notes, my colleague who saw documented that this patient experienced a lot of pain after her previous surgery and that they suffer fibromyalgia, for which they take 8 to 10 oxycodone tablets a day. And more to that, they've expressed concerns regarding the postoperative pain, and they've actually requested a nerve block if it will help to deal with this. At the same time, they also have fears and concerns around intraoperative awareness, which stem from a previous negative experience. So now we have something that isn't so straightforward after all, and clearly we've got a role for regional anesthesia. But even there, you can think a little bit harder about how exactly we should incorporate regional anesthesia into this patient's overall anesthetic plan. And you might be thinking, okay, pretty simple. Let's just do a brachial plexus block, whatever your go to is. And this isn't wrong at all. However, before we just jump to that conclusion, we might want to think about a few more things. So, just to sum up, what exactly we got here? We have a patient who has chronic pain, opioid dependence, and habituation, and who has a high probability of having severe postoperative pain. So, we could ask ourselves, what are our specific goals of care here? And ideally, what we want to do is to provide complete anesthesia of the arm with regional anesthesia so that we can completely eliminate the need for any opioids because this patient's requirements, both during and immediately after, are going to be high and somewhat unpredictable. Now, at the same time, we need to combine this with unconsciousness to meet the patient's expectations about not being aware. So, you despite the fact they're providing surgical anesthesia, you are going to actually give them deep sedation or even a general anesthetic with an airway in. But this is primarily for hypnosis. And because of this, then you could say that we're shifting our primary objective of the regional anesthesia more towards analgesia. And thus, it means that you don't have to have rapid onset of the dense surgical anesthesia. That's not a priority. Now, in addition, we should always think beyond the intraoperative and immediate postoperative period, beyond the PACU, as I like to say. So if we're taking the trouble to do a nerve block, we should try to make it last as long as possible in this patient. And I say in this patient because if you prolong sensory block and analgesia, you will likely also prolong motor block. And we should ask if this is going to be a problem. In this particular instance, having the patient paralyzed from the shoulder downwards for 24 hours may not be a huge issue. We can just support it in a sling until the block wears off. On the other hand, though, we could ask, do we actually need to paralyze her entire arm, given that the surgical area is actually just below the elbow? And if we can preserve a degree of motor control, then it's generally more reassuring for the patient. Plus, they'll be able to better protect their arm because they have a little bit more control over it. Now, one simple strategy for that is to avoid a supraclavicular block in favor of an axillary or infraclavicular block, because both of the latter two will preserve your shoulder abduction. I would suggest, though, that you could even go one step further and perform mid-humeral blocks, which will further spare elbow flexion and extension while still covering the surgical site. And so this is where we might finally end up in the decision making for this patient. We're going to combine anesthetic blocks with a light general anesthetic. We're going to use a long-acting local anesthetic, ideally with adjuncts, to get the maximum analgesic duration possible. And as for the specific regional anesthesia technique you're going to use, the basic approach would be an axillary or infraclavicular block. But an optimal approach, as I said, might be to perform selective mid-humeral blocks that will cover just the forearm and still allow the patient to control their elbow and shoulder after surgery. Remember, as I said, the patient's going to get a general anesthetic or deep sedation, so tourniquet application is not something you need to worry about. Finally, though, what do you choose? That really boils down to matching to your skill set, making sure that you decide on what is safest and most effective and feasible for you as the individual practitioner. And what we've just done here is an example of the first phase of decision making, which is to frame the problem or understand that what the situation is that's facing us. And this includes defining our goals of care very clearly and precisely and identifying any unique surgical and patient considerations that you need to take into account. And to distill this from that mass of information that we gathered as part of our history taking, I would say that two mental models are particularly useful. And the first one is to learn to think from first principles, which means that you want to drill down to the fundamental facts or truths about the situation. In this case, it was identifying the key considerations, exactly what we want to achieve in this patient, and then any conflicts that require compromise or creativity to resolve. And distilling anything to their first or fundamental principles allows us to understand why we do anything. It then allows us also to innovate, refine our strategies and interventions because we now understand their component parts. And this allows us to be both flexible and adaptable and not necessarily constrained by those fixed recipes, those rigid prescriptions. And certainly, you don't want to take any of it at face value. And related to that, then, the other mental model to employ is second order thinking, also called second level thinking. And this is a mental model now that encourages taking the time to analyze the situation in depth and to think through all the potential consequences of your actions. What you'll see here is one example of a framework for internal questioning that can help us to do this. So in anesthesia, learning to think across time is particularly important. And what I mean by that is to consider and anticipate all the possible consequences of each of the options that are open to us. And always ask, and then what? What will each action and its potential results mean for us and our patients? Now, apart from the unique surgical and patient considerations, the options and decisions that are available to us are also influenced by personal and environmental constraints. And the environmental constraints might include, the available resources you have, equipment, space, time available for you to perform the block, as well as personnel to help you. And speaking as from the personal point of view, those constraints will include the boundaries of our own knowledge and our technical skills, which define what we call our circle of competence. Another less obvious constraint is our mindset, which also limits the options that present themselves to us. The thing about personal constraints is that they're all open to change and growth. Now, further to that, I will say that one of the things I think that influences our mindset and our decisions and actions is what the convention and standard of care is. It is a natural human instinct to follow the tribe, to do what our peers would do. And I'll say that that's absolutely reasonable and very sensible. But being comfortable with occasionally stepping outside the mainstream has its benefits, though, because that's how progress happens. And in unique and challenging situations, this is often part of that necessary customization of care. So again, this is where first principles and second order thinking help. If we understand the rationale for why things are done a certain way, or how, say, clinical guidelines were arrived at, we can determine if, when, and how we might deviate from them as we try to get to an optimal plan. Let's look a little bit closer at guidelines. So, guidelines are drawn up by content experts who have done the work of digesting all the available information and then providing thoughtful and rational recommendations to us about an appropriate course of action to take. They are, though, still generalized suggestions, all right? And it's our job to not blindly follow them, but to interpret them for the individual patient that we're looking after. The best guidelines are derived themselves from first principles, and the very best will actually describe the reasoning and evidence behind the recommendations along with their caveats. Hence, I encourage everybody to read the actual paper, not just the summary, because if you understand these details, you can then be thoughtful in arriving at your final decision in gray scenarios. So, one good example are the Joint European Society guidelines on a common dilemma, which is how to use regional anesthesia when the coagulation status is abnormal. And common sense principles are emphasized as the foundation to these recommendations, which, as I said, we ourselves should take the time to read, internalize, and apply ourselves. So, for example, it may be quite safe to proceed with a block in abnormal coagulation if the site is distant from major blood vessels or critical structures, if the site is easily compressible, and if any bleeding or hematoma formation can be quickly and easily detected. And the guidelines also take the first principles thinking forward to make more nuanced statements. So instead of simply saying, neuraxial and deep nerve blocks should only be done 72 hours after the last administration of a direct oral anticoagulant like rivaroxaban or apixaban, they start to introduce the concept of the dose that was actually administered. And so in low dose administration, they revised their minimum stopping interval down from 72 hours to 36 hours for apixaban and 24 hours for rivaroxaban, applying a principle that only 2 half-lives is required rather than the usual 4 to 5. Because when you look at the pharmacokinetic data, after 2 half-lives, only 25% of that medication remains active. And in most patients, because they're starting at a lower dose and a lower baseline concentration, that means that their levels will come into the range that is regarded as negligible after a shorter time period. And they also take into account the fact that beyond this time point, elimination itself is slowing considerably. So you're reducing any marginal gains you're going to get from further delay. And I will note that the most recent 2025 ASRA guidelines have also similarly adopted this nuanced approach, also taking into account a consideration of the dosing of the drug when you're making your decisions. Now, taking it a little bit further, you can apply a similar thought process around full dose regimens to help our decision making in gray zones. So, for example, when you discover that the next total hip patient on your list who's scheduled for a spinal had their last dose of apixaban 60 hours ago instead of 72 hours, do you proceed then with the spinal anesthetic that they were expecting? This paper is quite interesting. It measured residual DOAC levels in 2,000 patients after pre-procedural cessation, and they found that by 60 hours, more than 80% of patients, which is that shown in blue, had actually achieved acceptable residual DOAC levels. And levels in the majority of the remainder were only mildly elevated. Now, I'm not saying that this gives us, a free hand to do the spinal, but rather that we should think about these things. And by incorporating and applying data like this, we can sort of weight the consideration of the patient's coagulation status and bleeding risk against the benefits and other considerations. And thus, what we're trying to do is arrive at a reasoned decision that serves this particular patient's best interest. And really, this is that classical risk benefit analysis at work. Because when we choose any possible consequence of action, we have to weigh the potential consequences of both the positive and the negative ones. And while we do this, what's really important is to guard against neither underestimating or overstating both risks and benefits, which again is where that first principles and second order thinking can help. And we should add to that it's useful to start to think in terms of probabilities rather than binary thinking. So, it's not just the magnitude of benefit or harm, but also to make an estimate of the likelihood that they're actually going to occur in the particular patient in front of us. So, weighing both the likelihood and consequence of any outcome should start to be part of your automatic process of decision making. And again, as an example, and continuing with this theme of regional anesthesia and abnormal coagulation, the Association of Anaesthetists in the UK published guidelines for hip fracture, and they take a very pragmatic approach that balances the benefit of getting surgery done in a timely fashion against the risk of spinal hematoma with spinal anesthesia. And in the case of a patient who is actually taking full dose DOAC therapy, if spinal anesthesia is strongly indicated for other reasons, they actually say that it's reasonable to proceed after just 2 half-lives or 24 hours if the creatinine clearance is normal. And, without a doubt, there are people out there, including some of you in the audience, who might think this is rather aggressive. But in their defense, I will say that they get through this through careful consideration, which they do lay out in their article. And one of the things they note is that the incidence of hematoma after spinal anesthesia, not epidurals, but spinal anesthesia, is actually very, very low, something like 1 in 120,000 patients. They do, however, tell you that you should be careful, though, because the risk may be increased in patients who have spinal deformity and if there are repeated attempts at needle insertion. And so it really falls to us to modulate that final risk assessment based on our examination of the patient, our confidence in our technical skills, and thus our prediction of how the spinal anesthetic might play out in this patient who's sitting in front of us. Now, even when we know the probabilities, it's not saying that we're going to eliminate all the uncertainty in the outcome of our decision. Um, General anesthesia is favored because generally it doesn't fail, with the exception of perhaps a failure to put your definitive airway in. On the other hand, though, I will say regional anesthesia failure is something that happens even to the best of us now and then. And biological variability is probably the biggest contributor to the unexpected outcomes in medicine and anesthesia. You can get genetic and epigenetic factors that may result in a lack of expected response to your local anesthetic, such as the described resistance to local anesthetic conduction block. But I would say, in just generally, there's this inherent variability too in how the local anesthetic will distribute in the tissues and diffuse through tissues and the CSF. The good news, though, is that some things are within our control, especially with regards to technical procedures like airway management or regional anesthesia in this instance, where just through training and deliberate practice, you can increase your mastery of a given technique, and thus you can increase the probability of success or safety in your hands. So, acquisition of advanced skills like, say, ultrasound imaging of the spine or a paramedian approach to neuraxial blocks, those kind of things will skew the odds in your favor. Nevertheless, I will also say that because there's always the possibility that regional anesthesia won't work as well as we had planned, it helps that you also have your fallback or your plan B. Um, However, that even isn't as simple as, oh, I'll just give a general anesthetic, because even in that instance, there may be important details to consider. So, for example, suppose you've just successfully completed your spinal anesthetic for a planned total hip replacement, a posterolateral that's going to be done in the lateral position. You have actually already turned the patient lateral. You're giving some ephedrine because the blood pressure is sagging, so you know your spinal is working. And then your surgeons elevate the leg as they begin to prep the skin, and the patient says, should I be feeling that in my hip? And you do a quick sensory test, and lo and behold, the sensory block to pinprick has ended at the mid thigh, L2 to L3. The question here I would put to you is, do you let your surgeons carry on with positioning and preparation, perhaps maybe tilting the patient to encourage the spinal block height to rise some more, and then hope that in the next 10 minutes or so that it takes to prep and drape your spinal will be adequate? Or do you tell them to stop the prep, ask them to turn the patient supine, and then convert to a general anesthetic? And even that decision, I'm going to suggest to you, hinges upon one thing, which is whether or not you're comfortable in your ability to insert a definitive airway for general anesthesia in a lateral position in this particular patient. Do you have the necessary skills and experience? Do they have an anticipated difficult airway? Now, if you're confident, put an LMA in a lateral position, then it's perfectly acceptable to carry on with option A, which was to let them prep and drape and get to the point of just pinching before they incise. Either that will be fine or it won't, in which case you say, okay, give me a few minutes, induce anesthesia, and slip in the LMA. But if you're not comfortable with this, then you should probably be making an earlier call to go to plan B in the general anesthetic, because you don't want to tell your patient at that stage, oh, I need you to take down all the drapes, I need you to reposition the patient because I need to put them supine. So this really illustrates a couple of things about formulating your plan B, which is once again anticipating considerations and constraints around the implementation and making sure that's within your circle of competence. But just as important then of the how of this plan B is the when, right? Because it's a decision that hinges not just upon how competent you are with putting the airway in, but also your confidence perhaps in the spinal height continuing to rise, which is influenced by other considerations. What exactly did you put into the spinal and how much? Isobaric local anesthetic is notoriously unpredictable in its distribution and not as amenable to the effects of gravity. And then the other thing is, are you confident that you delivered the entire dose of local anesthetic into the intrathecal space? So once again, going back to those first principles and second order thinking, help us to reason through the appropriate decision making so that we can solve this particular dilemma. So I want to end with some thoughts on how you can learn more effectively, how we can improve our knowledge and skills in service of decision making. And reading the scientific literature remains extremely valuable. However, I would say for regional anesthesia, what you want to do is carefully read the methods section of any paper. What exactly did the authors do? Because much of the success or failure of regional anesthesia is in the details, and small details make all the difference. For the same name block, you can get variations in the direction of needle insertion and injection, the volume and composition of the injectate, and all of this will influence whether local anesthetic reaches your intended target and what the results are that you can expect. And a simple example would be a femoral fascia iliaca block and its efficacy in analgesia of the hip, one of the plan A blocks for this indication. Yet, we can drag out this study that shows an ultrasound guided fascia iliaca block had no benefit in hip arthroplasty. However, when you look at the methods in the actual paper, you'll see that they use a transverse in-plane infrainguinal approach to the fascia iliaca block. And because local anesthetic travels very much in the direction that you inject, you can imagine that this will produce spread in a predominantly lateral to medial direction, which is fine if you're trying just to block the anterior thigh and knee, but it won't actually get to the articular branches that supply the hip, which arise more proximally in the suprainguinal location. And so for that, you need to inject in a caudal to cranial direction so that you get local anesthetic to all those relevant nerves for hip surgery. Now, another influence on the size of the observed differences between treatment groups is whether or not they're using things like multimodal analgesia. So this recent study on the same question of should you do fascia iliaca blocks in total hip arthroplasty is a prime example. So this time they did use an appropriate suprainguinal technique, but they still didn't see a reduction in the primary outcome of 24-hour opioid consumption. And again, once we dive beyond the abstract into the methods, what we see is that all patients receive this postoperative analgesic regimen. So it's not the fact that the block's not working, it's just that in this particular context, the block doesn't confer meaningful benefit, which they define as reduced opioid consumption. So unless your practice involves giving patients long-acting opioids routinely, these findings don't actually apply to us. So remember that you need to carefully consider not just the block details, but the details of the entire anesthetic and the treatment protocol that was used. And the last thing I want to say about papers is that as we look at the results, don't just focus on the central variable like the mean or median. Instead, what you want to do is look at the variance or the confidence interval for the data, because Again, this allows us to appreciate that range of possible outcomes that we can expect, as well as their probability, which then allows us to set our expectations accordingly and to make appropriate decisions around the margins of safety for success and complications and instituting our plan B. In the interest of time, I'm going to skip forward a little bit to say that as you learn from others, another invaluable way is to find good teachers. Now, teachers can be mentors or coaches or both. And the mentors are your guides on the journey, but coaches, on the other hand, are helping us to walk the path and travel that journey more efficiently and effectively. So, coaches show us how to do things better, how to improve our skills and performance. But what they both have in common is a wealth of experience that we can tap into to accelerate our own learning curve. And you all should take advantage of this array of mentors and coaches that you have here in KL and in all through Malaysia. But as the learner, our job when we find a good coach is to be coachable. So embrace feedback in all its forms. And the other thing you want to do is to be a proactive learner. So rather than just mimicking the actions of your coaches and your mentors, always seek to understand their first principles and their thought processes so that you know why they make the decisions that they do and all the little details that contribute to their success. And this requires that you ask thoughtful questions because a lot of times for us as experts, what we're doing is not something that we thought about. It's kind of unconscious and intuitive and not always easy for us to verbalize. So by asking us good questions, we can better explain ourselves. And ultimately, remember too that their circle of competence uh, may be different from yours at your stage of learning. And this again will change the probabilities of success or complications when you try to replicate what they do. And personally, I'm always mindful that I'm teaching methods that are within the capabilities of my own trainees. Once you finish training, though, the downside is that you are practicing in this vacuum. So those of you that are be out of training, there's no one really to watch you or give you direct feedback. But you can still appreciate and gain experience if you are being mindful, which means thinking about your cases, active reflection, and with procedural skills, this is also could be described as self-directed deliberate practice. So when you have both successful and unsuccessful outcomes, you want to ask, why did I fail or succeed this time? What was I struggling with? Or why did this go so smoothly? Should I do anything different next time? You want to deconstruct your technical skills into these discrete steps and analyze them individually. And the same goes for those decisions you made in the planning process. Again, in the interest of time, I'll skip through this story um, and just to say really that one of the most important things you can do is to practice, practice, practice ahead of time, ahead of that really crucial scenario, because you want to internalize and automate all of these things as much as possible. And in fact, in anesthesia, we're blessed with very short feedback loops. We know very quickly the outcomes of our decisions and our actions, and it's an incredible learning opportunity. So you want to take advantage of your routine day-to-day anesthetics and to use those to rehearse and build all these mental models as well as the technical skills that will be essential when things get challenging. And so, more than that, what you should try and do is seek out or even create opportunities to practice in low stakes situations for high stakes ones. So, what you could call sandboxes. As a simple example, you could practice elective spinal anesthesia in a position that's unfamiliar to it, be it this lateral or sitting position. Use a paramedian paraspinous approach. Don't bend the spine. See if you can get away with a straight spine. Using ultrasound imaging, use it when you don't have to. Because all these elective patients are a rehearsal for that emergency case in the difficult hip fracture patient who has real contraindications to a general anesthetic. And if you struggle in the elective patient, you always have the option of reverting to a more optimal conditions and trying again next time. But again, don't waste those opportunities to train and practice. Um, I'll end by saying that, the reward for engaging in all this effort to really think through the care of each patient in front of you and to practice on a daily basis is that that will make you a better clinician. And by better, I also mean more flexible and versatile. And ultimately, to develop this intuition that comes out of the repetition, which is really what is key to effective problem solving and decision making when you have crises and challenges, which ultimately I will tell you is, I think, what defines us all as professionals and experts. And so, with that, I'll end. Thank you so much.